The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, good morning, everyone, and welcome to today's webinar. It's vaccine-induced thrombotic thrombocytopenia, what we know and don't know. My name is Dr. Roshni Kulkarni, and I'm a professor emerita and former director of the MSU Center for Bleeding and Clotting Disorder and the Division of Hematology Oncology at Michigan State University. I'm also the past director of the CDC's Division of Blood Disorders and a founding member of the Foundation for Women and Girls with Blood Disorders. I will be moderating today's webinar. Next slide. So a little about the foundation. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every stage of life. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next. So you can see here that since its inception, the foundation has focused on realizing its vision through these objectives. And you can read those objectives, building awareness, providing education and training, encouraging successful collaboration and coordination of care between hematologists and reproductive health specialists. That's perhaps my favorite thing. I love having our OBGYN colleagues with us. And then link providers essentially to have the best practice, translate and disseminate, educate, support the next generation of healthcare providers caring for women and girls with blood disorders. So the next slide. So shows who are we? So this is our board, and you can see Dr. Andrew James is our president. Barb Conkle is a founding member, as I am. And then we have a wonderful, wonderful set of passionate, very interested, energetic, and we recently acquired two new board members, Jeffrey Lawson, who's a professor of surgery and pathology at Duke University, and of course, Sarah O'Brien, who is from Nationwide Children's Hospital Hemostasis and Thrombosis Center. So welcome to all of them and to the other ones. And Russell Ware, of course, is our sickle cell disease expert. When we first started, we had one man, and that was Ken Mann. And he has remained, and he is absolutely wonderful and really helps us with all our basic science issues and, leading the research efforts and things. So the next slide. So we have some housekeeping issues. So to ensure the best sound quality during the webinar, all attendees will be muted. However, you will have the opportunity to participate in a question and answer session with Dr. Aripalli at the end of the webinar. You can submit your questions during or after the presentation portion of the webinar via the chat box. I hope all of you can see your chat box in your GoToWebinar control panel on the right-hand side of your screen. And we will address them during the Q&A session at the end of today's presentation. Next slide. So a little bit about our faculty. I think many of you know Dr. Gao Aripalli from the Department of Hematology at Duke University. She's a professor of medicine and vice chief of research in the Division of Hematology. She received her medical degree from Vanderbilt University, finished her residency in internal medicine at Emory, and completed subspecialty training in hematology and oncology at the University of Pennsylvania. Her clinical interests are disorders of hemostasis and thrombosis with a focus on immune-mediated thrombocytopenia, heparin-induced thrombocytopenia HIT, immune thrombocytopenia, thrombotic thrombocytopenic purpura, as well as applications of therapeutic apheresis. Her long-standing research program involves translational studies of heparin-induced thrombocytopenia. Fundamental contributions from her lab include the development of novel animal models for studying HIT immune response, structural studies of the HIT antigenic complex, discovery of a new class of heparin-dependent antibodies to protamine heparin complexes in patients undergoing cardiac surgery, and identification of complement as a major contributor to the HIT immune response. In addition to her clinical and research interests, Dr. Aripalli is deeply committed to career development of trainees. She leads the Hematology T32 training program in Hematology and Transfusion Medicine, directs the Duke Strong Start Scholar Program for junior faculty, and serves as the Associate Program Director for the Hematology Oncology Fellowship Program. I can tell you this talk is so timely by Gao because she is an expert on this, and she's an outstanding speaker. So there are people who are clinicians, who are scientists, but Gao has the unique combination of being a clinician, a scientist, a teacher, and a mentor. So we are so proud of her. So the next slide shows her disclosure, and she has the following things to disclose. And Gao, if you have anything more to say about your disclosure.
Yes, I just want to point out that I have recently signed on with AstraZeneca because our lab studies some of the issues that they're seeing in vaccine-induced thrombotic thrombocytopenia. So I just want to point that out. And we have not yet started our consultations, but we'll soon start on those projects soon. And then my other,
yeah.
Another consulting includes Novartis, Verilox, BioKit, and funding from the NIH.
So now AstraZeneca is smart. They got an expert on their panel who will kind of help, I hope, everybody and direct their product. So the next slide will show that before we begin, we'll have a poll question. And we'd like to do a quick poll to see how many people are joining us today. And please take a moment to answer the poll question in your screen. Okay, so go ahead. I'm going to wait for a minute or so. All right, thank you for your responses. Any more people joining? So we'll please close the poll now. And I will now like to turn the call over to Gao Aripalli. Thank you, Gao.
Thank you, Rashni, for those kind words. And I'd like to sincerely thank the foundation for giving me the opportunity to talk about this newly recognized syndrome. And the title of my talk is Vaccine-Induced Thrombotic Thrombocytopenia, What We Know and Don't Know. And to highlight how rapidly evolving this the area of knowledge is in this syndrome. And so I thought I would focus on areas that we know right now and areas that we don't know as of now. And it may be because it's so rapidly evolving that people in the audience today may know more things than I don't know, which I list in the I don't know column. But suffice it to say, we have enough knowledge about this syndrome that I think we can have some firm guidelines on how to recognize it and how to manage it. So I just wanted to summarize that the information that we have a pretty good grip on today. So I have I'm going to kind of give you the highlights that I will be discussing in more detail. And so currently what we do know is that this is a truly rare and distinctive clinical syndrome. Sorry, I'm trying to see if this advances. Have I been up? There we go. And the reason it is distinctive is because we have sufficient information to know that it's a female predominant disease, that it presents with these unusual manifestations of thrombocytopenia and thrombosis, and that the thrombosis occurs in the cerebral vein bed for the majority of patients that have been reported, and or unusual sites such as portal or the splanchnic bed with rare cases of DVT or arterial thrombosis. The other thing we know, I'm trying to advance, sorry.
Let's do the, oh, there we go. Go ahead.
Okay, sorry about that.
You got it.
Is that it is a likely a class effect related to the vaccine vector using adenovirus rather than all the SARS-CoV-2 viruses. And so far, all the cases that have been reported have been with AstraZeneca vaccines and J&J vaccines. Oops. Now it's too responsive. We also know the pathogenesis of this syndrome. It has a striking resemblance, and in fact, is essentially a form of autoimmune heparin-induced thrombocytopenia. It's caused by antibodies that occur 4 to 14 days after vaccine administration, and it's associated with development of high-titer anti-PF4 antibodies, which we know can cause manifestations of thrombosis and thrombocytopenia in the context of heparin exposure, and they are likely doing the same thing with this disorder. And we also know that this is not a form of COVID-19 infection, that the immune response that is thought to propagate this syndrome is really a de novo immune response likely to PF4 that's either pre-existing antibodies or antibodies that are newly formed against PF4 and adenovirus, and that this de novo immune response is not the same as the SARS-CoV-2 protective antibody response. So we do have data suggesting that it is its own syndrome and not anything to do with COVID-19 infection or protective antibodies. So I'm going to take you through the features that we currently have a good understanding of. So first is that this is truly a distinctive clinical syndrome. And I think that's why it was picked up very quickly as a unique signal in response to the COVID-19 vaccination. And so the data that I will be summarizing today are gathered from 3 New England Journal articles and a letter, as well as a CDC report that was issued last week. And the clinical features that I will be highlighting today are taken from the case series that were reported in these 3 New England Journal articles. So, sorry. So in terms of presenting features, the numbers of cases are clearly small, as you can see here. 5 cases in the Schultz report, 11 cases in the Greiniger report, and Scully et al. Summarized data on 23. But they all have very, very striking similarity in terms of case descriptions. First thing to note is that the median age is young, so ranging from 22 years of age for the majority, with median ages of 36 to 46. The majority, over 70% of cases, are under 50 years of age. There is clearly a female predominance in all of these reports, ranging from 2.5 to 1 to 4 to 1 in these reports. The other thing to note is that these are generally healthy people that are not having significant comorbidities. Very few are associated with contraceptive or hormonal therapy. As you can see here, there were 3 in the Schultz report, but in the 11 cases by Greiniger, there was only 1 patient using oral contraceptive use. In the 23 that was reported by Scully, only 1 patient with oral contraceptive use. And none of these patients had pre-existing thrombophilic disorders or past history of thrombosis. In all of these cases, this occurred within days of being administered the first dose of the vaccine, with dates anywhere from 5 to 14 days. Majority presented with some form of thrombocytopenia, usually severe thrombocytopenia, ranging from 11,000 to 113,000, which is a moderate thrombocytopenia. What is really striking in all of these reports, which is distinct from heparin-induced thrombocytopenia, is that there is a predilection for cerebral vein thrombosis. And so, as you can see here, anywhere from 56% to 80% of cases had cerebral vein thrombosis. And the next common was occurring in the portal Slankneck bed with anywhere from 9 to 27% of cases. The occurrence of DVT and PEs was not as common as cerebral vein thrombosis, and not as many patients had arterial thrombosis, at least in the reported case series. A lot of the patients presented with manifestations of DIC with a low fibrinogen and elevated D-dimers, which has been reported with cases of severe HIT. In terms of other testing and treatment outcomes, of all the cases that were reported, the majority were negative for acute infection with SARS-CoV-2. And in some cases, patients had protective antibodies, but a lot of cases, the antibody levels were, protective antibodies were low due to the timing of the vaccine administration relative to when these patients presented. In cases where there were reports of thrombophilia testing, the majority of patients were negative for lupus anticoagulant, anticardiolipin antibodies, or thrombophilic mutations. And what is remarkable is that the majority of cases were positive for anti-PF4 antibodies. As you can see here, 96% of cases were positive for anti-PF4 heparin antibodies. In the Scully report, 81% were positive in the Reinecker report. And what you have to understand is that the format of the PF4 antibody tests is important. There have been reports that a certain format of testing, the immunoassay LIA assays, which are automated assays, were reportedly negative in some of these case reports, whereas this traditional ELISA format for PF4 antibodies tended to be positive in all cases. And then in cases where functional platelet activating antibodies, which are the hallmark for pathogenic antibodies in HIT, when those were tested, majority of those patients were positive for functional antibodies, suggesting that these antibodies are likely associated with disease manifestation. And in patients where the syndrome was not recognized as a HIT-like syndrome and where patients were administered heparin, some of those patients had poor outcomes and had worse disease. Although not in all cases, but a lot of patients did have progressive disease with heparin exposure. And as you can see here on the last column, last row, outcomes were poor in those that presented, and fatal outcomes were noted in 30 to 60% of cases. The next thing I want to talk about is the class effect. So we do have a good idea that this is likely related to the adenovirus vectors. And what makes me say that? Well, currently, I just looked on the dashboard for a number of vaccines that were administered in the US, and it's on the order of 200 million plus of single doses of vaccines that have been given in the United States. The majority of them are the mRNA-based vaccines by Pfizer and Moderna. And the technology for this is an mRNA-based vaccine that encodes the spike protein of SARS-CoV-2. It's encapsulated in lipid nanoparticles. And of those 200 plus million cases that have used these formats, so far the CDC has not received any credible report of a syndrome of thrombotic thrombocytopenia that has been reported with the AstraZeneca and J&J vaccine. And so one has to believe that since the majority of cases that have been reported have been with these two vaccine platforms, that there is something about the adenoviral vectors that's triggering this response. And so what about the adenoviral vectors? So AstraZeneca uses a recombinant chimpanzee adenoviral vector called ChAd-OX1, and it encodes the full spike glycoprotein, and that does not shed S1. It's been mutated to not shed. Whereas the Janssen vaccine uses a different type of adenovirus, it's an adenovirus, recombinant adenovirus, and that is a unmodified spike glycoprotein. Sorry, I misspoke. This is a modified vector SARS-CoV-2 protein, whereas this is the unmodified. So they use different forms of the CoV-2 spike protein in their vectors, but the vector is adenovirus. And there is still significant homology between the two adenoviruses that are being used as the vehicles for these vaccines. And the other reason that we think that this is a class effect is because of the similarity in presentation of the thrombotic thrombocytopenic episodes that have been reported with the AstraZeneca, which I summarized earlier, and the J&J vaccines that I will summarize here. And this is a case report that came out in the New England Journal of Medicine that provides a lot of information, even though it's one case in terms of the testing that they conducted on this patient. So this is a 48-year-old female who presented with a 3-day history of malaise and abdominal pain, received vaccine 14 days prior. She had severe thrombocytopenia, occasional schistocytes. The laboratories were consistent with the DIC-like picture with a low fibrinogen and elevated D-dimer. Consistent with the AstraZeneca report, she was negative for the acute infection. And this is a case where the LIA PF4 antibody testing was negative, but the ELISA was positive. The patient had extensive splanchnic bed thrombosis affecting portal mesenteric venous vessels, but she also had cerebral vein thrombosis. She was started on unfractionated heparin, developed progressive thrombosis, and converted her thrombotic cerebral vein thrombosis to a hemorrhagic one. And she also developed new thrombosis in the right hepatic and splenic veins. She was switched to argatroban, given IVIG, and had an improvement in her platelet counts to 145,000. So very, very similar in case description to the AstraZeneca reports. In terms of her testing, and this is why I wanted to show this, you could see that most of the hematologic parameters were normal. Platelets, of course, were abnormal. And in terms of lupus anticoagulant testing, anticardiolipin antibody, beta-2 glycoprotein, all of these were in normal range. This patient also had extensive thrombophilia testing, as shown here by antithrombin, protein C, protein S, factor V Leiden, that was negative. There was a marked inflammatory background, as indicated by elevated C-reactive protein. And you could see all of these other ancillary testing was normal, including hepatitis, HIV, transaminases were normal, haptoglobin was normal, PNH screen was normal, ADAMTS13 was also normal, as was a JAK2 mutation. So really highlighting that the thrombophilia in this condition is very, very likely tied to PF4 antibody expression. Now, this is a CDC summary that was posted last week in a slide deck. This was 15 patients that were had reports after 15 patients with vaccine-induced thrombocytopenia occurring after the J&J Janssen vaccine. Once again, very striking similarity to the AstraZeneca reports, median age of 37 years, median time to symptom onset was 8 days, all occurred in females. 12 of the 15 cases involved the cerebral venous sinus bed. There were no pregnant or postpartum patients. And in this cohort 2, where it had COVID-19 history by reports, but there was no documentation of serology testing. In this cohort, 2 patients were using oral contraceptives. There were a lot more patients with obesity in this cohort compared to prior reports, and very few other comorbidities. And in terms of location of the cerebral venous thrombosis, this was the types of involvement that were reported, and 11 patients had other involvement of other and vascular beds, including obviously the splanchnic bed as shown here. But in this report, there were a few more arterial thrombosis. There was a carotid arterial, femoral vein artery, and iliac artery. So a few more arterial thrombosis than the reports that were coming out of the AstraZeneca vaccine cases. And in terms of thrombocytopenia, you can see here that the majority had severe thrombocytopenia as opposed to moderate thrombocytopenia that you can see with HIT. And all of these patients, 11 of 15 patients that were tested, were positive for PF4 antibodies. And in terms of treatment, 6 patients were given heparin, and as they stated here, all patients who received heparin were hospitalized, but none of the patients who died, there were 3 reports of deaths, none of them received heparin. But a lot of patients were, once it was recognized that this was a HIT-like syndrome, they were switched to non-heparin anticoagulants and or given IVIG. And so as of this report, there were still a number of patients that were hospitalized and in ICU care. So now moving on to what we know about the pathogenesis of this syndrome. What we know is that this is likely a variant of autoimmune or spontaneous HIT. So spontaneous HIT has been, it's a very rare presentation of heparin-induced thrombocytopenia. What we know of heparin-induced thrombocytopenia, it's nearly exclusively a inpatient disease, because a lot of patients are exposed to unfractionated heparin, low molecular weight heparin in the hospitalized setting, and develop the immune complication associated with PF4 heparin and anti-PF4 heparin antibodies. But in the literature, and this was first described by Dr. Warkentin in 2006, or maybe a little earlier, there have been reports of spontaneous occurrence of this syndrome that have been very closely tied to the pathogenesis of this conventional disease of HIT. And these cases of spontaneous HIT have a presentation that's very similar to what we see happening with vaccine-induced thrombocytopenia. In all of these cases, there has been no proximate heparin exposure, and it's thought that disease development was triggered by either circulating glycosaminoglycans or polyanions that bind to PF4 and generate an immune response similar to PF4 heparin complexes when patients get heparin. Unlike the vaccine-induced thrombocytopenia cases, where most of those patients had no preceding illness, patients with spontaneous HIT often have a preceding infection and or surgery, most often orthopedic surgery, that is thought to trigger the immune response to PF4 antibodies. In all of these spontaneous HIT cases, they have demonstration of PF4 and polyanion antibodies, and so they show up on testing for HIT testing. And in all of the cases where patients were exposed to heparin, when they present with spontaneous HIT, heparin aggravates the disease and worsens clinical outcomes. And the management of these cases is primarily using non-heparin anticoagulants and use of intravenous immunoglobulins in some cases. And I just want to kind of highlight the similarities and differences. And this is not all 20 cases. This is just a list of about 7 cases that I summarized in a review article on heparin-induced thrombocytopenia, where I just discussed this autoimmune spontaneous hit. As you can see here, age is variable, but generally on the older side as compared to the vaccine-induced syndrome, where it tends to be in younger patients. The gender here does appear a little bit more female predominant. All of these patients, the majority of these patients have not been hospitalized, but they do have antecedent illness. So a lot of these patients had preceding illness or surgery. And, the thrombosis, though, is more characteristic of heparin-induced thrombocytopenia in that they have a mix of arterial thrombosis as well as venous thrombosis, and not a cerebral vein thrombosis, which is what is really distinctive about vaccine-induced thrombotic thrombocytopenia. And as you can see here, all of these patients have positive antibodies to PF4 and functional antibodies as detected by serotonin release. So this is very similar, but not exactly like spontaneous hit. And the distinctions being that cerebral vein thrombosis is really a unique feature of vaccine-induced thrombotic thrombocytopenia, and not so classically with either spontaneous or conventional heparin-induced thrombocytopenia. So what we also know about this pathogenesis is that when you look for PF4 heparin antibodies in patients who present, once again, this is data from Dr. Greinacher et al. In Germany, where they looked at 28 patients, plasma from 28 patients with vaccine-induced thrombotic thrombocytopenia. All of them had detectable antibodies to PF4 heparin complexes that lost reactivity with excess heparin, and this is very characteristic of PF4 heparin antibodies. They have a heparin dependence, and the majority of these patients reacted to PF4 alone as well. The other thing is that these patients have very high titer PF4 antibodies, and this is if you serially dilute these, and this is 5 cases that were reported here where they did serial dilutions of antibodies. You can see by the time they become negative in this assay, the majority had antibody titers of anywhere from 5,000 to 6,000, with I think a median titer that was reported at around 32, greater than 3,000 dilution. And if you look at the platelet activation, so keep in mind that platelet activating antibodies are very strongly associated with disease activity in traditional HIT. They are also found in patients with vaccine-induced thrombotic thrombocytopenia. But the difference in these patients is that they show reactivity with buffer alone. So whereas a lot of conventional HIT antibodies don't necessarily react in buffer alone, these patients do have reactivity with buffer conditions, and lose reactivity in platelet activation assays with low molecular weight heparin, but the activity resurfaces if you incubate it with PF4. These are all just kind of more kind of esoteric data in terms of the antibody activating profiles, but suffice it to say that these antibodies are functional and they are likely to engage cellular Fc gamma receptors, and that's basically what we are showing when we show platelet activation activity of the HIT antibodies, that these antibodies are capable of binding cellular Fc gamma 2 and triggering prothrombotic responses of platelets, neutrophils, and monocytes. The fourth thing we know is that this disease is not related to COVID-19 infection or COVID-19 protective antibody responses, because that's one of the first questions people had. They got the vaccine, maybe they developed a robust anti-SARS-CoV-2 protective antibody response, and maybe these antibodies just happen to be bad actors and are cross-reacting with PF4 antibodies. And so how do we know that? So this is, data from Greinacher et al., where they looked at sera from 222 patients that were infected with COVID-19 antibodies. And so they looked first to say, if you develop COVID antibodies, are some of those antibodies cross-reactive with PF4? And they also looked to compare that reactivity of the anti-COVID response with the antibody, the immune response that they were seeing in vaccine-induced thrombotic thrombocytopenia. And the methods they used was looked at the reactivity of these of these two cohorts using anti-PF4 ELISA, anti-spike, and receptor binding domain ELISAs. These are assays that look at COVID-19 antibody responses. They also did platelet activation and functional assays. In Germany, they use a HIPAA assay, whereas we use more serotonin release assays in this country, but it's a functional assay. And they also purified antibodies to PF4 and PF4 heparin from sera of patients who developed vaccine-induced thrombotic thrombocytopenia. And this is a preprint. I don't know if it's been accepted for publication yet, but what you need to know is what they did with this was they first looked at the 222 patients who had COVID-19 infection, and they divided those into two cohorts, those patients without thrombosis and patients with thrombosis. And with the hypothesis of being that if you're going to have cross-reactive antibodies to COVID-19 that recognize PF4, you would be enriched in this cohort, or those patients with thrombosis. And then they looked to see how many of these patients developed or how the sera from these patients reacted with PF4 antibodies. And so this is just the clinical information that's summarized here. As you can see, there is not a female predominance with COVID-19 or COVID-19 patients with thrombosis. And this is the age distribution of those patients. There is a younger age distribution here. And you can see here that of the patients who developed thrombosis, it's more traditional PEs. 2 patients had portal vein thrombosis, and 1 patient had cerebral vein an arterial stroke, not a cerebral vein thrombosis. So no cerebral vein thrombosis in this. So already the clinical information on COVID-19, we know this already from a 1-year-long experience, that thrombotic thrombocytopenia is not a typical manifestation of COVID-19. And this is shown here in this data set as well. When they looked at patients who developed and looked at the reactivity of these patients to PF4 heparin ELISAs, they only found that 8.6% of all patients total had antibodies that were cross-reactive with PF4. And as you can see here, the majority of antibodies were kind of low level, with 13 of the patients that were cross-reactive having low level of antibodies, and only 1 of the patients of the 10 with thrombosis having an antibody that was what we would consider a pretty high level. And if you looked at this 8.6%, or 18 patients were positive on the PF4 assay, you can see that none of them were positive for functional, this is a PF4 ELISA. Yeah, this is the functional assay, sorry. I'm getting tripped up here. So this is the functional assay. None of them were positive in the functional assay. So, the point of this study is that a typical patients who have typical COVID-19 infection do not develop a minority develop anti-PF4 antibodies, but none of these have the pathogenic characteristics of platelet activation that we're seeing with vaccine-induced thrombotic thrombocytopenia. So the next question is that are these antibodies, or PF4 antibodies that develop in vaccine-induced thrombotic thrombocytopenia, are they cross-reactive with SARS-CoV-2 or vice versa, or SARS-CoV-2 antibodies reactive with PF4 heparin? And so they looked at it more systematically by doing a series of ELISAs in using a couple of patient samples. So they took 2 patients who were recovering from COVID-19, who had high levels of antibody to SARS-CoV-2. They took 6 patients who developed vaccine-induced thrombotic thrombocytopenia purpura, and then they isolated from these 6, 2 of these patients, they isolated anti-PF4 antibodies, specific antibodies, or anti-PF4 heparin antibodies, and then did the mix and match, where they looked at the cross-reactivity of these types of antibodies with SARS-CoV-2 or PF4. So the first panel I'm showing here is the reactivity of these antibodies against the SARS-CoV-2 protein. So this is, the SARS-CoV-2 viral protein. So this is the S1 domain, the receptor binding domain. This is the full length ectodomain. So if you look at the COVID-19 patients who develop antibodies to COVID-19 or SARS-CoV-2, they are reactive in all of these assays using the viral protein, the SARS-CoV-2 viral. But if you look at the vaccine-induced thrombotic thrombocytopenic patients, they have minimal reactivity to SARS-CoV-2 protein. So the point here is that these patients are not developing an unusual response to the vaccine, to the SARS-CoV-2 protein. They're reacting to something else. And if you take the PF4 antibodies specifically, they are not reacting to the SARS-CoV-2. And what are they reacting to? Well, they're reacting specifically to PF4, to epitopes on PF4 and PF4 heparin complexes. If you take the COVID-19 patients here, you can see that they're not recognizing PF4 antibodies, and that's consistent with the whatever 222 patients that they characterize. If you look at the vaccine-induced thrombotic thrombocytopenic patients, they are only recognizing PF4 heparin. And this level of reactivity is very different compared to the reactivity to SARS-CoV-2. So these are a different population of antibodies, and the pathogenesis is really linked to development of PF4 and to reactivity to PF4 and PF4 heparin complexes. So now turning to management, what do we know about the management of this syndrome? So what I can surmise from the reports that are out there, in general, treatment with unfractionated heparin and low molecular weight heparin is not a good idea. In some of the cases, it clearly was associated with worsening disease. And I highlighted the J&J case report that was from the New England Journal of Medicine, clearly aggravated disease. And the reason being is that we know that the antibodies that are developing in this disease recognize PF4 polyanion complexes, and your unfractionated heparin and low molecular weight heparin are just gangbuster polyanions that can bind PF4. And so there's very strong theoretical reason to suspect that they will aggravate disease, and we have some clinical data. And also case series experience from spontaneous HIT suggests that treatment with unfractionated low molecular weight heparin is also a bad idea in patients who develop spontaneous HIT. So for all those reasons, I would strongly avoid heparin or heparin-related products in the management of this syndrome. And we have now a number of non-heparin anticoagulants that could be used, including the direct oral anticoagulants. So there's really no reason to reach for unfractionated heparin and low molecular weight heparin. We also have evidence that where platelet transfusions are used, they worsen progression, and that's because platelets are the source of platelet factor 4, which is the antigenic target for the antibodies found in vaccine-induced thrombotic thrombocytopenia. So another theoretical basis, but also supported by some of these case series that platelet transfusions worsen the disease. The IVIG and prednisone, more so with IVIG, we know that it works in severe refractory cases of heparin-induced thrombocytopenia, and the case report suggests that it does also improve platelet outcomes and recovery in this disease. And then non-heparin alternative anticoagulants, I apologize for this typo, are acceptable. And if there's no underlying risk of hemorrhagic transformation, this is where every case has to be individualized. You have to certainly consider putting patients on alternative anticoagulants. So the management of this syndrome is, this is an algorithm that Dr. Scully and colleagues, suggested in their New England Journal article, where patient presents with acute thrombosis and thrombocytopenia, or with isolated thrombocytopenia in the setting of a recent vaccine with one of these, adenoviral vectors. They recommend screening for D dimers and treating them accordingly with low D dimers. They suspect vaccine-induced thrombosis is unlikely. With high D dimers, they recommend additional evaluation and empiric treatment with IVIG and non-heparin anticoagulants, and testing for ELISA after treatment is initiated, and management accordingly. Reinecker and colleagues, who also published a case series in New England Journal, recommend a little different approach in that they recommend HIT screening right away and by a PF4 heparin ELISA. And this is the approach that I would recommend for us, because the PF4 heparin ELISA is very commercially available here. And then if the patient is positive on the ELISA, one can safely assume that this is driving the biology of this disease, and to get additional supporting evidence by platelet activation studies, and then confirming the diagnosis. And they recommend a variety of options, including high-dose IVIG, non-heparin anticoagulants, including DOACs, direct thrombin inhibitors, and fondaparinux, although once again, I would caution the use of fondaparinux because rare cases of cross-reactivity and worsening disease have been reported here as well. So, but we have ample choices now in terms of non-heparin anticoagulants. Avoid platelet transfusions and avoid vitamin K antagonists, because this does aggravate heparin-induced thrombocytopenia unless you have some kind of a thrombin inhibitor on board. So my recommendations are, really to do kind of a blend of those two, which is get your CBC, D dimer, anti-PF4 testing, preferably by an ELISA format. Evaluate for thrombosis, even minor symptoms. You really do want to make sure that they don't have thrombotic manifestations. And in my thinking that if they have, and because the management is really going to be driven by findings of thrombosis, if they have thrombosis and no bleeding manifestations such as cerebral vein hemorrhage or hemorrhagic transformation, they really should be on a non-heparin anticoagulant, because we know if you have clots, they're going to worsen if you don't have anticoagulants on board. So where you can safely administer non-heparin anticoagulants, I strongly recommend that for patients with thrombosis and no serious life-threatening bleeding, and consider use of IVIG in those patients, in those patients with severe thrombotic manifestations. And in patients with bleeding, such as, and a lot of those patients do have hemorrhagic transformation, who have severe cerebral vein thrombosis, then those are the patients you would have to work with your neurosurgery colleagues to identify the optimal timing for non-heparin anticoagulants, and then manage with IVIG and steroids. And so that's what we know. So I'm not going to spend the next hour telling you what we don't know, but I could easily use that kind of time. There are a lot of unknowns about this syndrome. So you know, what we know, I'm highlighting here, and what we don't know is really who is at risk for this, why cerebral veins, portal veins, you know, is there a seroprevalence similar to asymptomatic PF4 antibodies? What is the optimal testing strategy? You know, the indications are that the LIA is not useful as a screening test, but the ELISAs are. We don't know a lot about the pathogenesis. We don't know why the adenoviruses are triggering this immune response. Is it the adenovirus itself, or is there a pre-existing anti-PF4 antibodies that somehow get revealed by the inflammatory state of the adenovirus? What is the role of PF4 in this disease? And of course, what is the optimal treatment strategy? And those are all the questions that we really don't have a good understanding of. Sorry, something went wrong here with the. So that's all I have. I'm sorry I didn't leave much time for questions, but I'm happy to stay online and answer any questions you may have.
Yeah.
Thank you.
Well, thank you, Gao. And at this time, we'll proceed with the question and answer part of our program. As a reminder, participants can submit questions via chat box in your GoToWebinar control panel. So let's see if we got any questions. That was indeed an excellent, very timely talk. And I can tell you, yesterday when I saw this patient, I was wondering, what do I do? And she's 19, and I know one of the patients described was like 18. She's 18 actually.
Yeah, well, I just want to offer some commentary on this whole topic. You know, I was really very saddened when these reports started coming out because, one, it's a horrible complication, obviously, in otherwise young, healthy people, because the people who are dying were people generally not at severe risk for COVID-19, but were doing their part, you know, in terms of public health measures to control disease. So complication is horrible. But what's also horrible is that it's now, you know, the knowledge about these rare complications are really spooking the public about vaccines in general. And so it's had the dual detrimental effect of you know, scaring away people from the largely beneficial effect of these vaccines. We know even with the AstraZeneca and the J&J, you know, with the J&J vaccine, 6.8 million doses have been administered in this country. And the vast majority, obviously, 15 cases, according to the CDC, have ended up in this horrible complication, but the vast majority have done well. So really our task is to understand the biology better so that we know which patients should not be getting this vaccine and which patients should be okay to receive it. And I think from what I have seen of some of the CDC epidemiologic data, it does look like older patients who are at very significant risk for COVID-19 complications have very low risk for this vaccine-induced thrombotic thrombocytopenia. So certainly that age group may benefit from these vaccines, not only here in this country, but in the world where you know, these vaccine formulations, because they're at room temperature, are much easier to administer.
So we have a few questions, interesting ones. The first one is, are these anti-platelet factor 4 antibodies different from what is seen with HIT, or do they have similar features? I think
Yes,
you did.
that's a great question. I think it's too early to tell. What we do know is just from that limited data that I showed you of Greinacher, that these antibodies, look and sound and quack like a duck. So they have all the kind of features that the HIT antibodies have in all of the assays that have been used, whether it's platelet activation assays like Greinacher's or flow cytometry like what they use in the Scully report, or even serotonin release assays that have been used here in a few case reports. They're doing the same thing as the HIT antibodies. So we have reason to believe that it's the same type of antibody that's forming. And we know even in conventional HIT that these antibodies don't react just to PF4 heparin, but they bind to PF4 polyphosphase, PF4 glycosaminoglycan. So the partner to PF4 is not so relevant as the fact that it's a PF4 driven biology.
So we have another question. There is any study or paper that we can read? Can you recommend a few? I know there have been a lot of New England Journal articles and wonderful editorials.
Yeah, I think it's so rapidly evolving that, we don't have as yet. I am working on a review of this syndrome, but we don't have as yet a one-stop kind of a review. I think the New England Journal articles are the ones that will give you the best information on the clinical features of this syndrome.
So next question is, why do you think this is found in women predominantly? And I want to add one more thing. If a woman is on combined oral contraceptives or something and is ready to receive vaccine, would you hold that?
I don't think so. It's really a very interesting biological and epidemiologic question, and clearly one where it took 7 million people as a denominator to reveal this signal. So it's clearly something unique about these individuals, and whether we have to genotype them or study them, the ones that survive to understand why they were developing it is the next, $6 million question. I think there are just so many unknowns regarding the female preponderance, the cerebral vein predilection for thrombosis, why it's doing that, we just don't know. And this is where the follow-on studies in the next year will hopefully shed some light.
So I think Miguel Escobar has a great question. Would you recommend JJ or AZ vaccine to your young female patients? Putting you on the spot.
I'm going to punt that and leave it to the CDC. I think, this is where the issue is, if you have other alternative vaccines available, you should probably go with that for the young patients until we have more data. But I hate saying that because I think, it really is context dependent, right? Because if you're in sub-Saharan Africa, you don't have a lot of options. Or in India, where the epidemic is raging, like wildfire. What are your options? And so I think in those settings where you have limited, vaccine choices, and you are more likely to die from the under COVID-19 infection, and your AstraZeneca or some of these vaccines are the only choice, I would definitely, even for myself or my children, I would take it and then just monitor for symptoms, and clinically, like, this is not a silent syndrome. People don't walk in and suddenly have symptoms, they have headaches, they have nausea, they're not feeling well. And so you bring those patients in and treat them very quickly. And so I think that's the answer I would offer.
So there's another question. Any information on the 6 patients with VITT who received heparin if they worsened? As you noted, none of the patients receiving died.
Yeah, and this is just based on CDC data that was in the public domain. Unfortunately, I don't have details on these cases, you know, but I think because, as I was saying, it sounds like a duck, acts, quacks like a duck, walks like a duck. So we got to treat it like a duck. And this is until additional information is available. If you can avoid heparin, you should avoid heparin. And if you ruled out PF4 antibodies and other, and DIC and some of these other things that have been reported with this syndrome, then it may be okay to use heparin. But right now, we're in a good space. We have a lot of different choices for therapeutic anticoagulation. And so I think you should avail yourself of those choices until this has been.
Talking about choices, Alice Ma asks, nice talk. Are you aware of any VITT with other adenoviral COVID vaccines like the Sputnik or the Sino vaccines?
Yeah, so I think part of that is a reporting issue. I mean, I just don't know what kind of vaccine reporting strategies these countries have. One has to assume that, if you give enough of the doses, and I also don't know what the dose, levels of the adenoviruses are in those vaccines. And so that's an excellent question. And I think, time will tell as those vaccines are being rolled out in these countries.
Yes, so great presentation from Aisha Zia. Any thoughts on the length of time antibodies persist or whether antibody persistence will be associated with the recurrence of VITT? I think this is important because if they're talking about a second dose, third dose.
Yeah, no, that's a very good question. I think obviously if you develop the syndrome after one dose of the adenoviral vector, it's done, you're done. I don't think you should get another one. We don't understand memory responses in HIT very well, so certainly we're not going to have enough knowledge about this. That's another excellent unknown, which I will add to my list of unknowns. So I think it's whether you switch horses to an mRNA vaccine, I don't know. What I do know is that in general, you still have protective antibody development after one dose of vaccine. So I think, what I would probably do is have patients get screened for SARS-CoV-2 antibodies. Those testing is available. And if they're antibody positive, then I think, you're done. You probably are going to be okay. Whether you would risk re-exposing them to an mRNA-based vaccine, I just don't know. I don't know if we're going to have that information.
So I think I'm just going to add, because of lack of time, I'm just going to ask just maybe one more question. Why do you think this is found in women predominantly?
Yeah, so another excellent $6 million question. Clearly there's some disease susceptibility. We know, clearly the most obvious one is estrogen and, the biology, but it could also be, what we don't have is really a denominator on some of these cases in terms of, with these vaccines, where there are more women that were given these vaccines for some reason. That's one possibility. And so it's just the reporting bias. But the fact that, it was, even in AstraZeneca cases, there was that female predominance seen and it was over 30 million doses that were administered with AstraZeneca, suggests there's definitely some kind of a biological predisposition. And there's so many differences between the sexes. So beyond just estrogen, in terms of immunity, in terms of even things like vascular health and PF4 levels. So I think those are things that are going to be understood with time, but probably not anytime soon.
So this is all the time we have for questions today. As a reminder, you will be able to review this webinar for your reference or share today's proceedings by visiting the fwgbd.org and accessing this webinar under Archive Webinar. For those who may have questions on this material, we encourage you to visit Ask the Expert feature on our website and submit your questions online. So the next slide shows our next webinar, and you can see this is a very interesting one. It will be on May 12th from 12 to 1 on case-based conversation on neonatal alloimmune thrombocytopenia, fetal and neonatal thrombocytopenia by Jim Bussell, and moderator will be Dr. Andy James. Well, and you may visit the website to register. CME credits will be provided. So Dr. Arepalli, thank you very much for your very, very informative presentation. Excellent. The foundation is pleased to provide this webinar at no cost to attendees, and you will receive the evaluation immediately following this program. We thank you all for your attendance and look forward to your future participation in foundation programs. Thank you.
Thank you all, and thank you for the excellent questions. I appreciate it.